Schizophrenia causes distorted and bizarre thoughts, perceptions, emotions, movements, and behaviors. Schizophrenia is not a single illness, but is a syndrome with many different symptoms and varieties. In Box 16.1, there are two categories of symptoms: positive symptoms and negative symptoms. Please know these symptoms. Positive symptoms are symptoms that are added to a typical person. Typically, people don't have hallucinations. These are added to our typical person. Positive symptoms include delusions, hallucinations, ambivalence, bizarre behavior, perseveration, associative looseness, echopraxia, flight of ideas, and ideas of reference. There's a Quizlet posted in Chapter 16 modules for you to learn these terms and what they mean. Negative symptoms are taken away from our typical person. Most people have a broad affect. If we take that away, the person is then left with a blunted or flat affect. Negative symptoms include flat affect, blunted affect, avolition, alogia, inattention, catatonia, asociality, anhedonia, and apathy. Schizophrenia is usually diagnosed in late adolescence or early adulthood, typically about 18 to 25 for men and 25 to 35 for women. The prevalence of schizophrenia is only about 1% of the general population. In the United States, that means about 3 million people have been affected by this disease. Schizoaffective disorder is diagnosed when the patient has a mixture of both psychotic symptoms and mood symptoms. Mood disorders are also known as affective disorders. This is where the name schizoaffective comes from, a combination of schizophrenia and an affective disorder. You may see schizoaffective as schizoaffective bipolar type or schizoaffective depressive type. Onset of schizophrenia can be abrupt or insidious, but most people will slowly develop signs and symptoms. Usually we'll start to see social withdrawal, neglected hygiene, loss of interest in school or work, and unusual behavior. People will generally be diagnosed with schizophrenia after they've begun displaying some positive symptoms, like delusions or hallucinations, along with disorganized thinking or psychosis. With schizophrenia, the age of onset greatly impacts how the patient does later in life. Those who develop schizophrenia at a younger age have worse outcomes than those who develop it when they're older. For those diagnosed with schizophrenia, we typically see two clinical patterns. In the first, the patient will have ongoing psychosis and never fully recover, but the symptoms may change in severity over time. In the second, the patient can have episodes of psychotic symptoms that alternate with episodes of relatively complete recovery from their psychosis. As the patient ages, the intensity of their psychosis tends to diminish. As time goes on, many patients regain some degree of social or occupational functioning, and the disease becomes easier to manage and less disruptive to the person's life. A few may be able to live independently, but most will continue to have difficulty functioning in society, largely due to the negative symptoms or impaired cognition. There are some disorders that are related to schizophrenia, and these include schizophreniform disorder. With this disorder, the patient will exhibit an acute reactive psychosis for less than the 6 months needed to be schizophrenia. If the symptoms last more than 6 months, the diagnosis will be changed to schizophrenia. The person may or may not have impaired social and occupational function. Catatonia. This is characterized by marked psychomotor disturbance, which can be either excess motor activity, which is purposeless, or the opposite, with virtual immobility and can have waxy flexibility with the immobility. Catatonia can occur with schizophrenia, mood disorders, and other psychotic disorders. Delusional disorder. This occurs when the patient has one or more non-bizarre delusions. The delusions are believable. Brief psychotic disorder. With this, the patient experiences the sudden onset of at least one psychotic symptom, which can include delusions, hallucinations, etc. Symptoms will typically last anywhere from 1 day to 1 month. Shared psychotic disorder. This occurs when two people share a similar delusion. This most commonly happens with a person the patient is close to, a parent or child, siblings, and so forth. schizotypal personality disorder. This involves odd and eccentric behaviors that include transient psychotic symptoms. We don't know exactly what causes schizophrenia, although there are several theories. The biologic theories focus on genetic factors, neuroanatomic and neurochemical factors, and immunovirologic factors. Genetic factors include genetic studies that have largely focused on immediate families to determine whether or not schizophrenia is genetically transmitted. Studies have shown that identical twins have a 50% risk of schizophrenia if the other twin develops it. Fraternal twins only have a 15% chance. This shows a genetic vulnerability. Another study shows that children with a biologic parent with schizophrenia have a 15% risk, and they have a 35% risk if both parents have schizophrenia. Recent studies are showing that there are several genes that can contribute to a person developing schizophrenia. With the development of CTs and MRIs, we've better been able to study the brain structure and activity. Findings have shown that those with schizophrenia have less brain tissue and cerebral spinal fluid than those that don't. Scans have also shown that those with schizophrenia have enlarged ventricles in the brain and cortical atrophy. Research also shows decreased brain volume and abnormal brain function in the frontal and temporal areas of the brain with those with schizophrenia. Neurochemical theories include dopamine and serotonin. Excess dopamine is believed to be a possible cause due to drugs that increase activity in the dopaminergic system, sometimes include a paranoid psychotic reaction that's similar to schizophrenia, and drugs that block postsynaptic dopamine receptors reduce psychotic symptoms. Serotonin is believed to possibly affect schizophrenia because newer atypical antipsychotics, like clozapine, are both dopamine and serotonin antagonists. Studies have shown that clozapine can greatly reduce psychotic symptoms and ameliorate negative symptoms of schizophrenia. Immunovirologic factors theorize that exposure to a virus or the body's immune response to a virus could alter the brain's physiology of those with schizophrenia, but new findings have not validated this theory. More recently, researchers have been looking at the possibility of infections in pregnant women as a possible cause of schizophrenia. Waves of schizophrenia have been seen in several countries, a generation after influenza epidemics, and there are higher rates of schizophrenia in kids born in crowded areas in cold weather and in conditions that are hospitable to respiratory problems. Culture can be a big consideration when we're assessing symptoms of schizophrenia. Some cultures believe in voodoo and witchcraft, while others may consider this delusional. In some cultures, hearing God tell you to do something is part of religious experience, while in others it's hallucinating. We need to be very sensitive to cultural differences when assessing our patients. We may also see some culture-bound syndromes, such as Buffet de Laurent, that we discussed in Chapter 11. Different ethnic groups may affect the way a person responds to psychotropic medications as well. Some ethnic groups can metabolize drugs faster or slower than others. For instance, Asians may metabolize drugs like haloperidol slower than their Hispanic counterparts, so they may need a lower dose in order to have the same effect. Our main treatment for schizophrenia is pharmacology with antipsychotics. Chlorpromazine was the first antipsychotic available in 1952. Medications do not cure schizophrenia, but they do help control the symptoms. First-generation antipsychotics, or typical antipsychotics, are dopamine agonists, while the second generation are both dopamine and serotonin agonists. First-generation antipsychotics target the positive symptoms of schizophrenia, while second-generation work on both positive and negative symptoms. First-generation medications to know are haloperidol or Haldol, chlorpromazine or Thorazine, and flufenazine or Prolixin. Second-generation meds to know are clozapine or Clozaril, risperidone or Risperdal, olanzapine or Zyprexa, quetiapine or Seroquel, ziprasidone or Geodon, and paliperidone or Invega. Third generation to know are aripiprazole or Abilify, brexiprazole or Rexulti, and cariprazine or Vraylar. We have 6 antipsychotics that are available as long-acting injectables or depot injections. They are fluphenazine as Prolixin decanoate, haloperidol as Haldol decanoate, risperidone as Risperdal Consta, paliperidone as Invega Sustenna and Invega Trinza, olanzapine as Zyprexa Relprev, and aripiprazole as Abilify Maintena and Aristada. Long-acting injectables help with medication compliance since they don't need to be taken every day. Most can be taken every 4 weeks, and Invega Trinza and Aristada can be even longer between injections. Most of the long-acting injectables need to be taken with the oral medications until the long-acting medication has enough time to be absorbed by the body, but the oral medications will no longer be needed at that point. Antipsychotic medications can have a lot of disturbing side effects. Extrapyramidal side effects include acute dystonia, akathisia, and pseudoparkinsonism. We can also see tardive dyskinesia, seizures, and neuroleptic malignant syndrome. Dystonic reactions appear early in the course of treatment, characterized by spasms in discrete muscle groups like the eye or neck. They may be accompanied by the protrusion of the tongue, dysphagia, laryngeal or pharyngeal spasms, which may compromise the airway. They can be painful and frightening. We can give diphenhydramine, Benadryl, or benztropine, Cogentin, to help with these side effects. Pseudoparkinsonism usually appears in the first few days after starting or increasing a dose. We'll see a shuffling gait, mask-like face, muscle stiffness, cogwheeling, which is ratchet-like movements of the joints, drooling, akathisia, and we also treat this with medications. Akathisia usually develops when the antipsychotic is started. We'll see restless movement, pacing, and an inability to stay still. The patient may report an inner restlessness. This is usually treated with medications like propranolol. Tardive dyskinesia is a late-appearing side effect, and it's characterized by abnormal movements like lip smacking, tongue protrusion, grimacing, and so forth. It's irreversible once it appears. The medication will likely either be discontinued or the dose will be lowered. Neuroleptic malignant syndrome is characterized by muscle rigidity, high fever, and increased muscle enzymes. It's treated by discontinuing the medication. Other side effects of second-generation antipsychotics include weight gain, sedation, photosensitivity, anticholinergic symptoms, and orthostatic hypotension. Agranulocytosis is a side effect that can be caused by clozapine. It's the failure of the bone marrow to produce white blood cells and is monitored very carefully by a complete blood count, or CBC. The blood draw will be done once a week for the first 6 months of therapy, and then every 2 weeks. It develops suddenly and is characterized by an ulcerative sore throat, fever, leukopenia, and malaise. Those with schizophrenia may also have psychosocial treatment. This can include both individual and group therapy, family education, and social skills training. Hopefully you've all been able to see group therapy in clinical. You may have seen some social skills training on the units as patients participate in the milieu or in the group as they discuss and practice social skills. While schizophrenia affects thought processes and content, perception, emotional, and social functioning, it affects each person differently, so we need to assess each patient carefully to discover what that individual needs. Our nursing interventions will be different with the patient displaying positive symptoms, like hallucinations or delusions, than one with negative symptoms, like asociality and apathy. First, we need to look at the patient's history. Find out how that person functioned before the current crisis in order to establish their baseline. You can ask the patient to describe what their typical day looks like. Find out the age of onset. Remember that a person who develops schizophrenia earlier in life is more likely to have a poorer outcome. Ask about previous hospitalizations and their response to being hospitalized. Be sure to do a suicide assessment as well and ask about a history of violence or aggression. Assess for a support system. Who helps them when they need it, or who do they call when they have a problem? Assess the patient's perception of their situation. What happened that you felt you needed to come to the hospital, or what do you need help managing? Next, we need to assess the person's appearance. Appearance can vary widely from appearing completely normal to someone who is disheveled with odd clothing and bizarre behavior. The person may also have odd facial movements, or they may imitate your movements and gestures, which is echopraxia. The person may also move slowly, which is called psychomotor retardation. They may be catatonic or have no movement, changing positions only when you move them, which is waxy flexibility. The patient may have unusual speech patterns as well. Please see box 16.3 to review these patterns. Those with schizophrenia frequently have a wide variety of mood and affect. Remember that mood is the person's pervasive and enduring emotional state, while affect is the outward expression of their emotional state. Affect can range from flat, which is no facial expression, or blunted, which is a few facial expressions, to silly and euphoric. Affect may be incongruent. The person may laugh while talking about someone's death, or they may cry when talking about their last group. The patient may say they feel depressed, like nothing brings them any joy, anhedonia, or they may say that they're all-knowing and all-powerful. Thought processes are disorganized with schizophrenia, and information processing is disrupted. Thought process and content can be assessed from what the patient says. If the patient stops in the middle of a sentence and is silent for up to a minute, that is thought blocking. They may have tangential speech where they move to unrelated topics and never answer the questions they were asked. The patient may have delusions, which are fixed false beliefs that are not based in reality. There are several different types of delusions. Please see box 16.4 in your book to review these. We need to assess the patient's delusions to know what to expect and try and reorient the person to reality. Remember that we don't want to argue with a patient about their delusions. They're real to the person experiencing them. But we also don't want to agree with them. If the person is experiencing a persecutory delusion, they may act suspiciously on the unit and might make statements that someone is watching them. If the person has religious delusions, they may demand a Bible or other religious literature and talk about God talking to them. Hallucinations can affect any of the senses, but auditory hallucinations are the most common, followed by visual. We need to assess hallucinations to determine if the person is experiencing command hallucinations, where the voices tell the person to do something. We need to find out what the voices are telling the person to do, in case they're telling the patient to hurt themselves or others, so we can maintain safety for all on the unit. Those with schizophrenia frequently have impaired judgment. This impaired judgment may mean the person can no longer keep themselves safe or know when the need for food, sleep, or medical care. Insight is also usually impaired. This is especially true early in the illness when the patient and their family may not understand what's happening. Some are able to learn about their illness and get appropriate help as needed as time passes, but not all do. Judgment can be assessed by asking the person to solve a problem, such as, what would you do if you had a flat tire? Talk to the patient and see what they understand about their illness and the need to participate in treatment to assess their insight. Schizophrenia can cause a loss of self-concept, which means the person may not have a clear sense of where they end and where other people or items begin. This is evidenced in depersonalization, derealization, and ideas of reference. This can manifest itself in undressing or masturbating in public, having a distorted body image, and clinging to objects around them. Those with schizophrenia tend to be socially isolated. This can be caused by both positive and negative symptoms in schizophrenia, such as delusions, hallucinations, and asociality. They struggle to fulfill family roles like son, daughter, and sibling. The family may also struggle with the patient's unpredictable and sometimes embarrassing behavior. This can lead to the family feeling guilty and responsible, and the patient feeling that they're a disappointment as they're unable to live independently. Schizophrenia can cause self-care deficits. Patients may not be able to pay attention to normal grooming, particularly when they're experiencing a psychotic episode. They may not be able to recognize sensations like hunger and thirst, or the person may be paranoid that someone has poisoned their food or drink, and they may become malnourished. Antipsychotic medications can cause constipation, which can be compounded if the person is not eating or drinking. The patient may also not recognize the need for sleep. Polydipsia is excessive water intake, and some patients will drink until they become water intoxicated. This can cause sodium levels to drop and the person to have seizures. Once the assessment is completed, the nurse will analyze the data and come up with a plan of care that is individualized for each patient. Some possible nursing diagnoses include risk for other directed violence, risk for suicide, disturbed sensory perception, disturbed personal identity, impaired verbal communication, self-care deficit, social isolation, ineffective health maintenance, and ineffective therapeutic regimen management. It's likely that a patient with acute psychosis will require inpatient care. During this phase, the nursing focus will be on safety for the patient and others, orienting the patient to reality, and stabilizing the patient's thought processes. Outcomes may include the patient will not injure themselves or others, the patient will interact with others in the environment, the patient will express thoughts and feelings in a socially acceptable manner, and the patient will establish contact with reality. Nursing interventions will focus on safety for the patient and others around him or her. Interventions include promoting safety, but also remember to preserve the patient's right to dignity and respect. Establishing a therapeutic relationship and using therapeutic communication are crucial for when caring for patients. Interventions for delusions include not arguing with the patient about the delusion, establishing and maintaining reality for the patient, and using distraction. Interventions for hallucinations include presenting and maintaining reality for the patient, getting a description of the hallucination for the safety of the patient and others, and engaging the patient in reality-based activities, such as card games and listening to music. Interventions for socially inappropriate behaviors include redirecting the patient away from the problem situations, handling inappropriate behavior in a non-judgmental and matter-of-fact way, reintegrating the patient into the milieu as soon as possible, and teaching social skills through education, role modeling, and practice. A diagnosis of schizophrenia can be a big adjustment for both the patient and their families. Many times, the patient and family don't have a good understanding of the illness and the need for education. Preventing relapse is an essential teaching point. Box 16.5 in your book has early signs of relapse, which include mood swings, lack of sleep, poor nutrition, neglecting appearance, and forgetfulness. Other teaching points include how to manage the illness and symptoms, the importance of medication compliance and getting to follow-up appointments, avoiding alcohol and other drugs, performing self-care and getting proper nutrition, social skills, avoiding stressful situations, and participating in supportive organizations like NAMI. Late onset schizophrenia occurs after the age of 45. Schizophrenia is not usually the first diagnosis for elderly patients. Dementia and depression are usually considered first. Those diagnosed with schizophrenia do survive into old age with a variety of outcomes. They have an increased risk of developing dementia, with about a quarter of them developing dementia and having a steady decline in their health. About another quarter have a reduction in the positive symptoms, with the remaining people symptoms mostly remaining unchanged. Most people with schizophrenia live in the community, typically in a group home, with their family or independently. Assertive community treatment helps with medication management, social, recreational, and vocational needs, and provides support to the patient and their family. These programs help reduce admissions to the hospital. Nurses may also provide behavioral health home care. Nurse managers may also be assigned to help handle the challenges the patient will face in the community. This may include help with housing and transportation, keeping appointments, and money management. Mental health promotion involves strengthening the patient's ability to bounce back from adversity and manage whatever obstacles they encounter in life. Early intervention targets identifying signs of schizophrenia in late adolescence or early adulthood when symptoms first begin appearing. Signs to look for include changes in appetite, peculiar behavior, trouble sleeping, loss of energy, ideas of reference, and so forth. Once these high-risk people are identified, we can implement interventions to try and delay the progression of the disease.